school. So I found a lot of what I consider really neat things to help you learn it rather than just me talking about it. And then the diabetes, I really didn't feel like that we would be able to do a good job if we embedded it in this PowerPoint. So I'm going to send you one with maybe some exercises for the diabetes because, it's tricky to take care of little kids with diabetes. So I want to put in that PowerPoint the best evidence for what you do when, because I think that's a real critical disorder for the endocrine system that really requires more thorough explanation than if I put it in this PowerPoint I would be able to do for you. And I want some exercises and stuff in there to kind of help you. So you will have an addendum to tonight with diabetes, and I'll try to make sure that it's clear and understandable and then give you some practice with taking care of a little kid with diabetes, because I'm sure that that will be on your certification exam. So we want to make sure that we cover that really well so that you are very knowledgeable when you take your test, and certainly, even more importantly, when you go out to take care of little kids. So this PowerPoint's packed with a lot of really neat stuff, which you'll be able to view. I think it's fairly entertaining, so it's not going to be dry like a lecture might be. So we'll see what you think of it when you are able to do it on your own. But anyway, we'll go ahead and get started. And what we are going to talk about is the endocrine and metabolic disorders today. And one of the first things I try to do is to give you a place to go, because I know it's been probably a little while since you've had your anatomy and physiology. So these sites will give you a review of the anatomy and the physiology in case you've gotten rusty on any of them. And I've started trying to do that with each one of the sections, so you have a quick down and dirty review, because I think unless you know the physiology well, then it's really hard to make sense out of what's happening to your patients. You have to figure out what works right before you can know what goes awry. So please do, if you feel like you absolutely have forgotten about the endocrine system, go ahead and click on that, at your leisure, and be entertained by the anatomy and physiology of the endocrine system. Those aren't, most of those aren't dry. Then there's 20 questions to test your knowledge. So there's a test for you after you go through doing the first slide that will test how much you remember from your anatomy and physiology and also the endocrine system. Okay, to assess the endocrine system, there are certain things that you want to look at. I think it's become pretty clear now throughout all of these systems that one of the most important things to pay attention to is the child's growth pattern. Is their head growing like it should? Are their heights and their weight on a steady increase? Are the height and the weight paralleling each other on those charts? So anytime you see a child's growth pattern change, either they're all of a sudden they're growing by leaps and bounds, or they've stopped growing. In many of these conditions of the endocrine system, some of these kids start out okay, and then sometime within infancy, there's a marked diminished growth pattern. So whenever you're looking at children, one of the most important things you want to look at is the growth and development, and to look at the charts. and make sure that they're looking the same. So if you have a little kid that's, say, on the 10th percentile, yeah, they're small, all right. But if they keep that pattern up, then look at the parents, because they're probably not going to be big people either, and that's okay, you know. We have all shapes, sizes in people, and it's okay to be little if there's not anything going on to make you small. So is the child taking any medications that might affect the endocrine or metabolic function? One of the things is, now we know that a lot of people are into homeopathic medicine, and so they'll be taking herbs and potions and all those kinds of things. So it's important to ask not just about, you know, medicine that you might get from the pharmacy, but are they doing anything else to help? That's my daughter checking on me, making sure I got the camera on. She was checking on me to make sure I got all hooked up. She's my technology expert in the 20s. You guys have grown up with that. I'm not so much. But anyway, so be sure and ask if they're on any herbs or things that they picked up at the nutrition store. Any signs of endocrine or metabolic dysfunction, and we'll talk more in a little bit about what to look for with regard to that. Exposure to iodine during the pregnancy of the mother might contribute to problems in the endocrine system of the baby. You'll want to know how long they've had symptoms. Is this a recent thing, or were they born with these problems? And has anybody else in the family ever had endocrine or metabolic disorders? A lot of these, and you'll see a slide soon in this presentation where you can click on the link, and you will be amazed. Honestly, I don't expect you to know all of those things because there are so many metabolic disorders, but that won't really come to play until you actually look at the link and see just how many things can go wrong with us. It's really amazing that things go right with us, honestly. So click on that link, which you'll see in a little bit, and you'll see how many different things could possibly go wrong. The good news is that there are many common signs and symptoms of things that could go wrong with the endocrine system that will help you. It might not diagnose what the disorder is, but at least you'll know that there's a disorder, and you can refer them to the endocrinologist, because a lot of these patients, that's where they're going to go. They're going to be sent to the endocrinologist. Some of them, most nurse practitioners, especially with children and their growth patterns, will affect how much medicine they'll need. They really need to be, you need to be working collaboratively with a pediatric endocrinologist. Sometimes those are hard to find. So in assessing the child again, do they smell funny? Have they been vomiting? Or they're just tired all the time and there's no reason for it? There's no anemia or anything there. So here are some links for you. The first one is examining a patient with problems with the thyroid gland. It goes into more than just the examination of the thyroid, which you should be doing if you're doing well child checks on children. If they're 3 and older, you should be doing the thyroid gland check. And you know that you just have them turn to the side, and you hook your hand in the side of their neck, have them turn to the other side and hook, and then have them look down, say, at their left knee, and then you can press and feel on one side, and then have them look at the other and press and feel. But it shows you how to do that, and then the next video presents, I think this is really neat, it presents clinical pearls for you in the endocrine exam to raise red flags for you and your patients. So they go through, they're all short videos, they go through what to look for just the very meat of what to look for in your examination. Genetic counseling. This is what I was talking about. This is an unbelievable list of endocrine diseases that are genetically linked. So have a look and see for yourself. There is enormous. I've never heard of some of them. There's just a gigantic number of diseases that are genetically linked that can be passed on from child to the child from the parent. What kind of diagnostic studies might you need to do? Some of these you might not be able to do, but what you want to do is measure the end products of the metabolism that's gone awry, that's either elevated or diminished. So you're going to be measuring like ammonia, glucose, galactose, amino acids, and like I said, in some places where you work, it may not be possible to do some of these examinations. But you want to do bone age, because the bone age has to compare with the actual age of the child. In many of these endocrine conditions, there's a disparity. Either the bone age is behind or it can be ahead of the actual age of the child. So bone age is one thing, and usually they'll do that with the wrist x-ray. Ultrasound, you might want to do that, for example, of the pelvis of a girl who has early menarche, or the testicles of a boy, to determine, if there's a tumor or something going on there. And then lastly, the MRIs and CT scans to rule out any kind of CNS, because you either have, with endocrine diseases, you either have from the central nervous system, which is called central source, or you have peripheral source, which is like from the thyroid or from the ovaries or the testicles. So you have to rule out, is this coming from the brain, or is it coming peripherally from other parts in the body? I think one of the, there's lots of conditions that little kids can get, but problems with the endocrine, if they're untreated or undiagnosed, can really lead to irreversible intellectual disability, physical disability, neurologic damage, and even death. When we're talking about Addison's disease, for example, can lead to a rapid death. So these are really serious conditions, and they're hard to diagnose and hard to treat. So if you have a child that has an endocrine disorder, a lot of these are chronic, then you really have to look at how are the family adjusting, the child adjusting, siblings adjusting, peers adjusting, because remember, any chronic disease in a little child is going to have an effect on how much time the siblings will be able to get. So that's a family dynamics problem. Do they understand their disease? Because if they do not understand what's happening to them, they're going to have trouble accepting it and taking care of themselves. So it's really important that they have the education to know what they have and what is done for it. Because it's chronic, you're going to have trouble with them adhering to their regimen. This is true for people like diabetics in this category, who may, during adolescence decide that they really don't need their insulin shots anymore. And that's when you start getting into trouble with adherence with young children who are diabetic. A successful outcome depends on the patient and family receiving the support and encouragement they need to continue to take care of themselves, continue to learn, and understand what their role is in managing this long-term, oftentimes chronic condition. Caring for patients with endocrine disorders, this is a nice site that goes into what you can do to help these patients. So it's like a down and dirty again, very short. And this is a PowerPoint slide with the endocrine disorders in children. And this one is medications. It has in this medications for endocrine disorders, it has flashcards, it has all kinds of stuff, quizzes. It's not long and involved. It just meets you at learning about the medications that are normally used in the treatment of endocrine disorders. So you can play with it. There's, I think, 5 or 6 things across the screen, 5 or 6 ways to learn the medicine. So it's a very interactive slide. And then if you want to know about growth retardation, you can even think about your own height. Target height for boys is the mother's height plus 5 inches and the father's height added to that divided by 2. The target height for girls is the father's height minus 5 inches plus the mother's height divided by 2. So if you want to know, if you're just seeing somebody for the very first time, you might ask, if they're coming and you think they have an endocrine disorder, if the parent is not there, then you can ask the heights of the father and the mother. And you can think about your own parents now and see if that actually works for you. So when we get through, sometime in your leisure time, you can figure out, did you really meet the standards here for growth? So think about if you had a really tall father and a really short mother, how are you going to come out with that? And did you come out like the formula says that you should? So osteochondrodysplasia, you see a whole family here. Certainly this is a growth failure. A lot of times it's in the legs, that long bones of the legs do not grow. So this is just for you, it's like they're dwarfs. The dysmorphic, these are like what you might see with people with endocrine disorders. So this little child has low set ears. You can see that they don't go, upturned little nose, a thickened upper lip. The upper lip is sticking out there. And micrognathia, where you have a chin that's somewhat limited. It doesn't look like the other people around. And the other thing you can have, I saw a little boy this week who had a really big forehead, and that goes along with the dysmorphic. The little childlike face and then this bigger forehead also is seen in dysmorphic syndrome. So again, it's looking, and I study when I'm out. Like we eat at Cracker Barrel a lot. Little kids come in, I'm like looking at them like, is this one normal? What's wrong with this one? So it's good to, start doing that, like, so you can get in your mind, what does a normal kid look like? And then if you find one that's not looking normal, then you can look at the parents and say, oh, okay, well that explains it. Parents are kind of funny looking too. Another thing with growth and development in the endocrine is like malnutrition, and here's certainly an example of malnutrition. If you look hard, you can see on many of these little children, their ribs. And the other thing you can see is their little pot bellies, because they have what's called kwashiorkor. And you might have studied that when you did your health assessment course. It's just a lack of protein. They're getting calories, but they're not getting adequate protein. And so what happens is all this edema and swelling, and that's what these little kids look fat maybe in their bellies, but actually they're malnourished. And you can see the little umbilica sticking out, and sometimes they have like weakened muscle, and that would contribute to that sad picture. And then the other part of malnutrition is called marasmus, and that's where you don't get anything. You don't get enough calories, let alone protein. And you can see the ribs on this little feller and all of his joints. He may be dehydrated as well because I see the IV fluid. And if you look at the little baby on the left, how wrinkly his little arms are. So it's just malnourished can be part of the endocrine metabolic disorders. Here's a little baby with hypothyroidism. You can see everything looks a little puffy on this baby, and his tongue looks like it's ready to stick out. It's also called cretinism, just due to a lack of thyroxine in his system. So if he doesn't get treated within 3 months, he'll begin to deteriorate intellectually. So it's really important to pick that up early. This is another case of metabolic problems. On the left is craniotabes. That's where you, if a baby has rickets and you press on their skull, it will pop back out like a ping pong ball because, their bones are not mineralized like they should be. And then on the right side is rickets. We don't see that, in our country like we used to because of the iodized salt that and we get, vitamin D, fortified milk. So, but there is vitamin D resistant rickets, so it doesn't matter how much vitamin D you get, you still might end up with the curvatures. One's knock-kneed and the other's bow-legged. Growth hormone deficiency, I don't think I skipped a slide. Just let me make sure now, because I was having a little trouble with it moving. Okay. So there are conditions in which the growth hormone is deficient, and so you need to ask when you do a physical exam, do you detect, or does it look like they might be chronically ill or have that dysmorphic syndrome? Look in their eyes. Anytime you get a chance to look at the fundi of the eye on anybody, do that, because the more you look, the better you're going to be. So, practice. Ask people if they would mind if you looked in their eyes. Your classmates, your patients, the preacher, whoever you want to ask. Gather up some people, and if you get a chance, look in the fundi of the eye. Palpate the thyroid gland. We talked about you need to check that in H3 and up. What is the stage of puberty that they're in? If they're in stage 1 and they're 14 or 16 years old, that's a problem. That's a big problem. Measure their body proportions, because the arm span shouldn't be longer than the span from your head to your toe. If it is, then we always think about Marfan's syndrome. Treatment, growth hormone is the treatment, is 0.15 to 0.30 milligrams per kilogram a week, and that's done with daily subcutaneous, I put infections, but it's, sorry about that, but it's injections. The side effects of giving growth hormone are glucose intolerance, scoliosis, slip capital femoral epiphysis, which you should have remembered from the last lecture or so, where you have rapid growth and then the femur kind of slips out of the acetabulum. Growth of moles and pseudotumor of the head or edema. So those are the side effects for growth hormones. Constitutional growth delay is really the most common cause of short stature and sexual infantilism in the adolescent. So the puberty is delayed, and you have a late adolescent growth spurt, and these are otherwise known as late bloomers. But the final height is finally normal, and the bone age may be delayed. Usually this runs in families. You see that the parents or one of the parents had a constitutional growth delay. They were just a late bloomer. But everything else will eventually catch up okay. Growth excess, we talked about Marfan syndrome. Abraham Lincoln had Marfan syndrome, and if they hadn't shot him, then one of the problems with Marfan syndrome is the aorta stretches and it can rupture, and that's how these folks can die. So their fingers and toes and arms and legs are disproportionately long. They're extremely tall and slender, have a long, narrow face. If you want to look at Abraham Lincoln's picture, I think you'll see that. Their sternum can either be indented or protruding. They have dislocated lenses of the eyes or high pressure in the eyes. And they have trouble with, their lungs. And they have really flexible joints. I'll show you, I think, an example of that in the next slide. Flat feet, curved spine, and abnormal heart sounds. It is inherited. And like I said, Abraham Lincoln, one of our presidents, had it. It's important to assess the aorta in these patients. And here's what I was talking about with Marfans. You see how they're very flexible with their thumb, and see how long their thumb is. And then you can see the arm span is longer than the head to toe span in Marfans. Another excessive growth syndrome is Klinefelter's, and here's a guy with Klinefelter's. I think we talked about that already. If we haven't, then this slide will give you a link to information about the Klinefelter syndrome if you've forgotten what it was. Pubertal disorders. 95% of all girls will have signs of puberty by 12 and achieve menarche by 14. We know that nowadays girls are maturing earlier, and boys too, for that matter. Boys begin puberty between 9 and 14 years of age, and the first sign of puberty is testicular enlargement in boys. The Tanner stages are very important when you're thinking about endocrine disorders. Precocious puberty is when you have puberty before you should. Thelarche is early breast development, and there's not anything that really you need to do about that except pay attention that other things might be awry, but there's no intervention for Thelarche. Pubarch, early pubic hair distribution. Again, look at your Tanner stages to see if, when you do your physical exam for a well-child check, one of the things you should be doing is looking at these children's bottoms. I hope your preceptors are doing that, because that's an important part. You don't want to eliminate any part of the body when you're doing well-child checks. Adrenarche is onset of both or either pubic and axillary hair in either boys prior to 10 or girls prior to 8. Excuse me. It's not associated with other features of true puberty. This may be caused by a mild form of adrenal hyperplasia exposure to testosterone, topical, I don't know what the word's in there, but exposure to testosterone, or they have adrenal tumor. Most often it's idiopathic, but they have an increased risk of polycystic ovary syndrome or metabolic syndrome. Isolated menarche is uncommon, so when you see that, you need to think about sexual abuse. Vaginal tumors, estrogen-producing cysts, are primary hypothyroidism. So just remember that you need to do some more research when you see that. True precocious puberty is the onset of multiple features of puberty earlier than the normal range, before 8 in girls and 9 in boys. The symptoms include accelerated linear growth, breast development, or penile enlargement, and pubic hair development. So if you see this in children, the diagnostic test you want to do are the 17-OHP, looking at progesterone, or the 24-hour urine collection for 17-keto steroids, or imaging of the adrenal glands to exclude the adrenal tumor. So nothing, again, I said, for premature thelarche. You also want to check their thyroid function with the panel, thyroid panel, and for the premature menarche, you'll want to do a pelvic ultrasound to rule out problems in the pelvic region of the little girls. True precocious puberty, you want to do an LH, FSH, and estradiol or testosterone levels. If high, then you'll want to do an MRI. If low, then you want to complete GnRH, stimulation test, to rule out central etiology. Remember, again, you're trying to figure out the problems. Are they coming from the brain? Are they coming from the endocrine glands? If peripherally you think that's the problem, then you want to do an ultrasound of the girl's pelvis or the boy's testicles. Treatment, of course, is always done with the help of a pediatric endocrinologist. Delayed puberty. If no puberty signs by 14 in boys and 13 in girls, then they need to be sent to an endocrinologist. If there's no menarche in girls within 5 years of breastfeeding, or a 10 or 5 in boys within 4.5 years of initiation of puberty. So those are all, warning signs that you need to try to commit some of these to memory, even though it's sometimes hard to remember all of those signs. Turner syndrome, here's a little girl, certainly an endocrine metabolic disorder, and you can see the web neck. This is a fairly common syndrome, so you probably have seen people with Turner syndrome. They are usually infertile, and boys and girls can have Turner syndrome. So Turner syndrome is chromosomal disorder in females, complete or partial absence of the second sex chromosome. So they have 45X karyotype. And then you can see some of the problems that go along with it. They're usually short, they have moles, they have problems with their cholesterol panels, they can have some hearing loss, wide space nipples or poor breast development, tooth anomalies, their teeth look terrible a lot of times. They can have trouble with their heart, they can have trouble with their renal system, and then you saw what they look like, in their face and upper body. Addison's disease is one of the diseases that, if not treated properly, can result in coma and death. So you're going to have in Addison's an inadequate supply of cortisol and aldosterone. And with the kidney, then what you have is water and sodium loss. So you have low blood pressure and low blood fluid volume, which can lead to shock and death. And then with cortisol, the enzymes in the stomach diminish, so you have vomiting. The liver doesn't function to, store glycogen, so you have low sugar. Extremely low sugar then results in death and coma. So you can see how once the crisis begins, it affects the vital organs. The sooner you can do something, the better. And families, parents do treat these children at home with hormone replacement, best again regulated in cooperation with the pediatric endocrinologist. So they get, whenever they go through any kind of stress, parents know that they need stress doses of hydrocortisone succinate with febrile illnesses, surgery, or trauma. So if they're in the hospital, they'll get IV hydrocortisone. And if they're at home, they probably will get IM, especially if they're vomiting and can't retain liquids. The long-term treatment, however, is oral, and it can include the fluorocortisone acetate if they have trouble with aldosterone deficiency as well. So if you give them cortisone, then the excesses can result in hypertension, acne, compulsive behavior, delayed puberty, weight gain, and osteopenia. So that's the result of the toxicity of steroids. Cushing's syndrome is when you have too much cortisol production, and it results in easy bruising, central obesity, and osteoporosis. The treatment here is surgery, radiation, and medication. And this is a slide that includes a YouTube video on transgender. Because certainly with some of these conditions, you can get gender confusion. And this, I think when you are dealing with a child with transgender, you need a certain amount of insight into them and their family and what they're going through. And this YouTube video really shows how parents are dealing with children that have transgender issues. And it's short. It really puts you in the place of the parent and the kid. And these parents are doing an amazing job working through the transgender issues with their children. Hypothyroidism, this really walks you through actually a baby with hypothyroidism. Again, all of these YouTube videos are relatively short. They're very informative, and I encourage you to watch them. I spend a lot of time finding them, so hopefully you'll find them educational. Hypothyroidism is treated with replacement doses of levothyroxine sodium, and the dose varies with the age. So when you're looking at this, one of the things you certainly immediately notice is that the older the child is, the less thyroxine replacement that they're going to have. So normally we think when children are small that their doses are going to be small, and as they get older, you're going to increase the amount of medicine that they get. What this slide shows you very well is that that's not the way it works with thyroxine. You're giving 10 to 15 micrograms to a 0 to 3 month old, and 2 to 3 micrograms to what really amounts to is an adult. Hypothyroidism is treated, of course, to prevent brain damage. Once you treat them, then the testing to make sure that everything's functioning like it should, it's recommended to test every 2 to 4 weeks after you start the treatment, and then monthly once the thyroid stimulating hormone has leveled out. and you do that until they're 6 months old. So if you have a child that has hypothyroidism, remember that you're going to be checking in to make sure that their hormones are where they ought to be very frequently. Every 2 to 4 weeks is very frequent for the first 6 months of age. And then after that, you could treat, test them monthly or every 2 months. And then for older children, half a year to a year until they get their growth complete. So what would tell you that they need more medicine? Certainly an elevated thyroid stimulating hormone, because the brain is saying, I'm making more stimulating hormone so that you'll produce more. The thyroid will produce more thyroxine. Or if the level of free T4 is low, then that can indicate a need for an increase in the dose of medicine as well. And if they're being followed by a pediatric endocrinologist, you probably will be calling them the lab results and saying, I noticed that, the level's low or high, and do we need to do something? This is certainly a typical picture of a hypothyroid patient. They always look like they just saw something really scary. It can cause people to think that they're in mania, amount of psychosis, because these folks are really wired. They have palpitations and diarrhea and arrhythmia, and then you see the exophthalmos. So they have tremors. And on that video earlier that I was talking about where you're examining a patient with thyroid problems, one of the things that they look for on this patient is they have the patient hold their hands out, and what they're trying to observe for is the hand tremors. These people are like on steroids, Treatment of hyperthyroidism. This video is not, it's probably misnamed, the topic, but what the doctor is talking about is when you have patients that do not respond to thyroxine, how do you handle it? So it's a little bit more advanced than what you read in your book. It's talking about recalcitrant patients that are not responding to treatment. So it's a good video. Obesity. This is a documentary on obesity. Again, all of these are very short, but it talks about, that we have an epidemic of obesity. And it talks about your role as a caregiver in that problem. If you do have a little kid that's obese, one of the things I think, one of the important things for you to know is what kind of diagnostic test do I need to do? Certainly you want to do a glucose tolerance test, because if you have obesity, one of the problems you're looking at is the potential for metabolic syndrome. So you want to rule that in or rule it out. The other video that I showed you, the documentary on obesity, please do watch it, because it alerts you to the one life-threatening thing that can happen early to cause a little kid to have a liver transplant. And there are not all that many livers around. So there's a steatorrhea, hepatitis, that is actually lethal. So one of the tests that you want to do, and it happens early, like by age 12, is you want to do an AST and ALT to check their liver enzymes to make sure they're not elevated and they're getting, fatty infiltrates into their liver. Then, obviously a fasting lipid panel, thyroid function, because you can have hypothyroidism, which can make you gain weight. Sleep apnea, because remember, when a lot of hormones are produced, they're produced while you sleep. Large input of your growth hormone, for example, happens while you sleep. So if you don't sleep very much, you're not going to produce growth hormone, and that helps again with your immunities too. You want to do a free and total testosterone level. Make sure that you measure their blood pressure. And you want to rule out orthopedic problems like that slipped capital femoral epiphysis. And then, because they're obese, that goes against their psychological well-being. And some of these children have low self-esteem, behavior problems, or depression. And that's one of the, really worrisome symptoms in a young child, because children beginning at age 7 certainly are capable of committing suicide. A lot of them do it by hanging themselves. So what are we doing for our children? Again, another excellent video on obesity in children, and what are we doing? Unfortunately, a lot of the research that's done to help children who are obese has not really proven out. There is no gold standard for what do you do with a little kid that's obese. Not yet, anyway. So, when do you give statins to children? We used to never consider, or even talk about for that matter, giving statins for dyslipidemia to children. But now we know we better, especially if they're 8 years and older. And we've done everything else like diet and lifestyle changes, but they continue to have, for example, elevated LDLs, high blood pressure, their BMI is greater than 97%, and they're running along with diabetes, kidney disease, Kawasaki disease with aneurysms, and their HDL is not elevated, and they smoke. So we know that we're beginning to prescribe little kids statins. And that was really, honestly, unheard of years ago. But kids got out, and they worked, and they ran, and they played, and we didn't have those ginormous portions of food that we have now that really would make at least 2 meals instead of 1. Phenylketonuria is PKU, and in your OB, I know that you studied it in all likelihood if you've had OB already. But this is a Mann story. It's just excellent to give you empathy for people that are having to deal with this. One of the things he says is that I spend $13,000 a month on the formula that I drink. That doesn't have phenylalanine, in it, because that's their problem. They cannot metabolize phenylalanine, which is one of the essential amino acids. So this is really neat thing. So how do you know if it's an inborn error of metabolism? Your book lists a whole bunch of these. But I think the most important thing, because there's no way that you're going to be able to diagnose an inborn error of metabolism right off the bat. The best that you could hope for is to figure out just generally that there's something going on. Well, consanguinity is one way. If they're marrying their first cousins, and that happens, then you may end up with an inborn error of metabolism. You may end up with more than that, for sure. If they decompensate when they're ill, in other words, they don't get better as fast as other people do. We've already talked about developmental delay, psychomotor retardation, and failure to thrive. If there's a family history of this, certainly you need to be alert about whether this child has it or not, and if the siblings have died for unknown reasons. If their symptoms begin with a change in diet, or again if they smell funny, like their sweat, their urine, even their earwax doesn't smell right, then you need to be able to think about, do they have an inborn error of metabolism? I think nurses don't use their noses as much as they should, because you can use it to smell strep, and with inborn errors of metabolism, you can use that. Here is a little YouTube with galactosemia. This is from a little kid's point of view. It's pretty cool to hear a child talk about how he, conceptualizes galactosemia. And he explains it to you in his own language, which makes it really easy to understand. And then there's like 2 of these, so it'll help you. So we're at the end of the slides. Are there any questions for me about anything, for that matter?